This conference will now be recorded.
రాజేష్ లాగిన్ అయ్యానులే. యా, థ్యాంక్ యూ. రోల్ నెంబర్ 3. రోల్ నెంబర్ 10.
Yes, sir. Yes, sir.
connection పోయిందా? క్లాస్ ఆన్లో ఉందా? అది ఇప్పుడు మళ్ళీ ఇప్పుడు మధ్యలో వచ్చింది. వాటి ఎట్ట వెళ్ళి వచ్చినట్టున్నావు ఒకసారి. అవునా? అవునా, నాది పెట్టాను. పెట్టంగానే ఇంట్లో వైఫై కనెక్షన్ పోయింది. మళ్ళీ ఇప్పుడు మొబైల్ నుంచి కనెక్ట్ చేశాను. అది ఇన్వర్టర్ కనెక్షన్ లేదు, పోయింది. అందు గురించి వస్తుందిగా ఇప్పుడు? కనపడుతుందా? నేను చెప్పేది వినపడుతుందా? వచ్చింది కదా స్క్రీన్. నేను చెప్పేది వినిపిస్తుందా? ఒక నిమిషం ఉండు. ఇప్పుడు ఓహో, బిల్ట్ ఇన్ అవుట్పుట్ రావట్లా, సంథింగ్ ప్రాబ్లం. వాట్స్ ద ప్రాబ్లం? వినిపిస్తుందా ఇప్పుడు? అవునా? ఇప్పుడు వినిపిస్తుందా? వినిపించలేదా? లొకేషన్ 147. బిల్ట్ మైక్రోఫోన్ ఇప్పుడు వస్తుందా?
హలో సార్.
ఇప్పుడు వస్తుందా?
సార్ ఒకసారి ఫోన్ కట్ చేసి
లొకేషన్ 147.
వినిపిస్తుంది సార్.
లోకేష్ రావు.
వినిపిస్తుంది సార్ ఇప్పుడు.
అవునా, పర్లేదు. ఓకే ఓకే ఓకే. సో I assume that all of you people are hearing person in random. Charita GV Krishnaraju 34. GV Krishnaraju.
Yes, sir.
Able to hear me?
Yes, sir. I'm able to hear you.
Good. So we'll start with the class. So today we are going to about this one very important and contemporary topic, that is oral hypoglycemic agents. And last class with insulin, which was forming one of the treatment for treatment of type 1 diabetes mellitus and also type 2 diabetes. Mostly patients who are not enrolled with oral hypoglycemic agents. So now coming to the topic proper, that is oral hypoglycemic agents. In this topic we'll be discussing about different pharmacotherapeutic options, different classes and groups of drugs which are used in the treatment of diabetes mellitus. So as we know that the pathology of type 2 diabetes mellitus mostly lies within the fact that there is inadequate release of insulin from the beta cells of pancreas, as well as there is increased peripheral resistance to the insulin that is available in the body, mostly concentrated towards the muscle and fatty adipose tissue. So the classification of oral hypoglycemic agents will go like this: oral antidiabetics otherwise. So the ones which enhance insulin secretion, and there are in this we have two different groups of drugs. One is sulfonyl urease and other one is megalithinic analogs. In sulfonyl urease you have two generations of drugs, so you can write down or check in your textbook as such. So these are the ones which will enhance the secretion of insulin. They will, if meaning to say that if there is some 30% of the beta cell mass still functional or present, these drugs will go and stimulate the secretion of insulin, which should happen naturally with the stimulus of food given to the through oral route. So here they will enhance the secretion of the insulin by their action through different mechanisms, which I'll elaborate in slides to come. So I have sulfonyl urease and megalithinic analogs, and you can see here there are first generation and second generation of sulfonyl urease. First generation are tolbutamide and chlorpropamide. Second generation are glibenclamide, glyphosate, glyclazide, and glimepiride. And megalithinic analogs, they are repaglinide and nataglinide. Repaglinide and nataglinide. Then we have other group of drugs. They are like Dpp4 inhibitors. They are third group, that is sitagliptin. The examples are sitagliptin, vildagliptin, saxagliptin, alogliptin, and linagliptin. And then again you have the agents which decrease the insulin resistance or peripheral insulin resistance. They are biguanides, in which you have predominantly one of the most important and gold standard drug in the pharmacotherapy of diabetes mellitus, that is metformin. Then you have thiazolidinediones. So there you have again examples which are acting by activating the receptor PPAR gamma. That is, the example is pioglitazone. So these are the two important group of drugs. What we have to remember in the agents and the agents which decrease insulin resistance. And apart from these two major group of other agents which are alpha glucosidase inhibitors, in which you have acarbose, megalithinic. Arjun Rao.
Sir. Hello, sir.
You're following? You're following, no?
Hello, sir. Yes, sir.
You're following my class, huh?
Yes, sir.
Okay, fine. So you guide me through the class, whether you are able to get me or not, so that I can get a idea whether if people are following or not. Okay.
Okay, sir.
Then yes. So these are other agents, and then coming to topic proper. So sulfonyl urease first generation. So these are the ones. So the prototype of them being the tolbutamide, and onset of action is within 1
Sir,
hour,
మళ్ళీ
will
first slide
last 6 to 12 hours.
Sir,
ఫస్ట్ స్లైడ్కి వెళ్ళిపోయావా?
ఫస్ట్ స్లైడ్ కి వెళ్ళిపోయింది. ఓరల్
slide
హైపోగ్లైసెమిక్
కనపడుతుందా
ఏజెంట్. అవును సార్.
ఓహో. ఓకే. ఇప్పుడు
కూడా ఫస్ట్ స్లైడ్ కనిపిస్తుంది సార్.
వచ్చిందా? అవునా?
అవును సార్.
Now
ఫస్ట్ స్లైడ్ కనిపిస్తుంది.
I think perhaps this is due to the weak connection, I suppose. But ఒక పని చేద్దాం ఉండు. So I'll try to change this Wi-Fi network. Just hold on for couple of minutes. I'll be back.
ఓకే సార్.
Mallikarjun Rao?
Sir,
Yeah. ఇప్పుడు version is it better now?
అంటే స్లైడ్ మారింది సార్. ఓవరాల్ హైపోగ్లైసెమిక్ ఏజెంట్ ఫస్ట్ జనరేషన్ వచ్చింది సార్ స్లైడ్.
వచ్చింది కదా? ఓకే, ఇప్పుడు నుంచి
అవును సార్.
వస్తుంది అంటే మళ్ళీ నాకు వైఫై ఆన్ అయిపోయింది. సో యు ఆర్ ఏబుల్ టు సీ నౌ జనరేషన్ టాల్బిటమైడ్ కనబడుతుందా? ఓకే,
రాలేదు సార్,
So-
ఫస్ట్ జనరేషన్ తో ఆగింది.
ఇప్పుడు వస్తుంది, వచ్చిందా?
రాలేదు సార్.
ఇప్పుడు okay, you listen. Okay, if it comes it will come. I will tell you the rationale, like you have seen the classification slides, no? Now you are able to see this, huh? This one, this slide.
నో సార్, ఇంతకడే ఉంది సార్.
Not even with Wi-Fi connection, why it's not coming? Can we log in, log out and log in all together again? Me? Will it help? You are able to see now, huh? Mallikarjun Rao?
స్లైడ్ కనిపిస్తుంది కానీ ఇంతకే ఫస్ట్ జనరేషన్ కూడా ఆగిపోయింది సార్ అది మళ్ళీ.
అంటే ఇప్పుడు ఇట్లా జస్ట్ ఇప్పుడు నేను స్లైడ్ షో పెట్టలేదు, స్లైడ్ షో పెట్టకుండా మామూలు జస్ట్ స్లైడ్స్ ఏవైతే ఉంటాయో పెట్టాను. ఇప్పుడు ఏమన్నా కనపడుతుందా? ఇప్పుడు ఏం కనపడుతుంది స్లైడ్?
ఓవరాల్ హైపోగ్లైసెమిక్ ఏజెంట్స్ ఫస్ట్ జనరేషన్ అని కనిపిస్తుంది సార్.
అంతటితో ఆగిపోయింది అంతేనా? ఇంకా ముందుకు వెళ్ళట్లా?
ముందుకు వెళ్ళలేదు సార్.
ఇప్పుడు అంతే ఉంది?
లేదు సార్, అక్కడే ఉంది సార్, అంతే ఉంది సార్.
Okay, I will do one thing. I think actually these are the slides which have been done like by line. Means if every line it will come as I click the button to move it forward. Maybe due to this network lag and this slide sequence, it's being difficult to tell you, but I will try to tell you orally. This is all given in books, so just understand the rationale of it, like what is the classification, what are the classifications we have, what are the drugs we have, how do they act. So almost all insulin secretagogues, means the agents which secrete insulin, they share a similar mechanism of action, and the drugs which decrease the peripheral resistance, they too act by same mechanism of action. And other agents like alpha glucosidase inhibitors and some of the other agents, they have a different set of actions as such. So you try to follow it up with whatever I tell with regard to these drugs, so that we can at least finish the class. And if it comes, it's well and good that you can see it, or else I'll try to send this PPT or do some alternative arrangement for it as you finish the class. So sulfonyl urease, so these are agents which are insulin secretagogues, means which will increase the secretion of insulin. So of which the first generation is talbutamide. For any group of drugs, whatever it may be, there will be some 5 to 10 drugs. So the important point about them is what function do they do. Here in this case, they are going to increase the secretion of the insulin, first thing, and how better or how fast do they act. So what is their onset of action? Is it well within 30 minutes, 1 hour, 2 hours or so? So depending upon their onset of action when they are going to act, and duration of action of how many hours or how many minutes they are going to act. So these are 2 important determinants. So as the rationale goes, if you are going to give a drug which is an insulin secretagogue, it means that as soon as the patient normally takes food, anything, maybe breakfast or lunch, so the food should go and it stimulates the secretion of insulin in the GIT. But if that's not happening, we are giving a tablet simultaneously, maybe 30 minutes before or 15 minutes or before. So all the insulin secretagogues are advised to take along with the food. So as you take the food, the tablet is taken, or at least maybe say like half an hour before, something like that, as we do with insulin. So then that will go, then that will produce the brisk secretion of insulin from the pancreas by stimulating the beta cells of the islet mass and produce the insulin which is needed for the glucose metabolism as such. So these are different group of drugs, salbutamide, chlorpropamide. But the drugs or agents which are of importance are not the first generation one, but the second generation. So we have glibenclamide, glipizide, gliclazide. So if you people go to hospital and see on bedside, like what are the different agents that are available at our dispense in the patients, for the patients we are treating for diabetes mellitus, then they would be mostly be second generation agents, like glibenclamide, glipizide, gliclazide, and so on. And in these drugs also, depending on their hello. And so these are the different agents that are there. So we have glibenclamide, glipizide, and gliclazide, and then you have glimepiride as well. So this glimepiride is one drug. Glimepiride is one drug which is very commonly used as such in all the preparations. Glimepiride is one drug which is used, and gliclazide is also one more important drug which is used for the management of type 2 diabetes mellitus from the group of drugs which are to be used in the treatment of diabetes mellitus as the agents which are helping in increasing the secretion or as insulin secretagogues. And so we can interchangeably use any of these agents, say like glibenclamide, glipizide, gliclazide, or glimepiride, depending upon the patient glycemic status. So we have to see what are his fasting levels, what are his postprandial sugars, or what is his stable HbA1c parameter that is there. So by seeing all of these things, we can get an idea of what drugs we have to substitute and what drugs we have to give in combination therapy as such. Then coming to sulfonyl urease, what is the mechanism of action? They stimulate the insulin release from beta cells. And how do they act? Means they inhibit the sulfonyl urea receptors present on the ATP sensitive potassium channels. So this is one very important mechanism. They inhibit sulfonyl urea receptors present on the ATP sensitive potassium channels. That will lead to depolarization followed by calcium entry. So that will lead to insulin release. And also simultaneously the glucagon levels are suppressed. So these drugs, as with along with other drugs, they are well absorbed and their plasma protein binding is high. They are metabolized in the liver and they have certain adverse effects. So now that they are insulin secretagogues, and any increase in the insulin production or secretion due to their overdose can cause hypoglycemia. And now that insulin being an anabolic hormone, that can also lead to weight gain. And one of the important limitation of it is if they are taken by a pregnant mother, this drug can cross the placental barrier, reach the mother, baby, and cause fetal hypoglycemia. So that is why this one drug should be avoided in gestational diabetes mellitus. And then Megalithinides analogs. These are another group of drugs which are almost all acting with the same mechanism of action as that of the sulfonyl urease. The important examples are repaglinide and nateglinide. In repaglinide, again the dosage changes. Repaglinide is given in the dose of 0.25 to 4 mg before each meal, and its onset of action is within 1 hour and lasts for 4 to 5 hours. Then another one more important group of drug from that stable is nateglinide, where the hypoglycemia risk is low as compared to other sulfonyl urease and other drugs, and it is given in the dosage of 60 to 120 mg before each meal. and almost all it shares the same onset of action and duration of action compared to that of the repaglinide, which is the prototype or congener in the megalithinides analogs. And sugar level or blood glucose surge which happens insulin in the body. So this postprandial hyperglycemia is one aspect which is and megalithinides analogs. Then there are certain advantages. There are certain advantages of rapaglinide, nataglinide, or repaglinide. They are like flexibility in mealtime dosing. That's why it's called as Ramzan drug. So you can make flexible changes in the mealtime dosing for that particular drug. Then there is no significant increases in the body weight. So as compared to the sulfonyl urease, which are sharing the same mechanism of action, there is no body weight gain as compared to that of the sulfonyl urease. And these can be utilized in mild to moderate renal failure. And also nataglinide is the drug which is approved in hepatic failure. Now that in the context that sulfonyl urease have certain limitations with regard to their metabolism and excretion in liver and kidney, so taken to this particular drug nataglinide can be used in patients who are having diabetes as well as hepatic failure. Then what are other useful situations where megalithinides analogs can be used in place of sulfonyl urease? So elderly patients in whom hypoglycemia is a concern, and patients with kidney failure or mild hepatic impairment. So these are the patients where we can use. Then patients taking low dose sulfonyl urease who encounter problems with hypoglycemia. Means they are taking low dose sulfonyl urease, yet they have the problem of hypoglycemia. Usually, as I told, attributed to its very mechanism of action, hypoglycemia would be an obvious symptom in patients who are taking sulfonyl urease, and there is some inadvertent increased doses. Maybe you are not getting enough response and still you increase the dose. So that is the case. But even in spite of using the therapeutic recommended dose of sulfonyl urease, say like glimepiride, glibenclamide, gliclazide, so then also if you are having hypoglycemia, then this is the drug. These are the drugs, megalithinides analogs, which can be taken to control the CH Manoj. Are you there?
Sir. Sir.
You are there.
Yes, sir.
Good, good. వినిపిస్తుందా కనిపిస్తుందా? ఓన్లీ వినిపిస్తుంది, కనిపిట్లా అంతేనా?
యూస్ఫుల్ సిచ్యువేషన్స్ స్లైడ్ ఆన్ సార్. యూస్ఫుల్ సిచ్యువేషన్స్ స్లైడ్ ఆన్ సార్.
వెరీ గుడ్, వెరీ గుడ్, వెరీ గుడ్, వెరీ గుడ్. ఇప్పుడు మారిందా?
లేదు సార్, ఇంకా యూస్ఫుల్ సిచ్యువేషన్స్ ఉంది సార్. ఇప్పుడు మారింది సార్. మోడ్స్ ఆఫ్ యాక్షన్.
అలాగ ఓకే, రైట్ నాన్న. సో ఇక్కడ this is one important slide which will give you an idea about one important hormone, endogenous peptide hormone, GLP-1. So how will it be secreted and what is its action? So these are some things that one need to remember. So as far as this GLP-1 mode of action in humans is considered, so what will happen is upon the ingestion of food, GLP-1 is secreted from L cells in the intestine, and this in turn will stimulate the glucose dependent insulin secretion and suppress the glucagon secretion. It slows gastric emptying, reduces food intake. So these are some of the important functions which are deliberated by the GLP-1. So it stimulates the glucose dependent insulin secretion, and it increases the beta cell mass and maintains beta cell efficiency. So this one important GLP-1 is one important neuropeptide hormone that we need to remember, because as you can see, is taken and the GLP is produced from the L cells of the intestine. There is one enzyme called as Dpp4, that is dipeptidyl peptidase 4. So that enzyme will come and cleave the polypeptide GLP-1, deeming it inactive. So if it is inactive, it cannot help in the glucose dependent insulin secretion or release and in preserving the beta cell mass and all other functions. So this GLP-1, which is endogenously produced from the L cells of intestine, has a short duration of action, maybe like say 2.6 minutes, especially when given intravenously. So this Dpp4 is the enzyme which will come and cleave the GLP peptide, thereby the actions of the GLP-1 mediated through glucose dependent insulin secretion will be disturbed. So in window is we will use dipeptidyl peptidase 4 inhibitors are the drugs which will come and inhibit the enzyme Dpp4 which is cleaving or making the GLP-1 ineffective. But GLP-1 is one peptide which is very important secreted from cell cells of the intestine in facilitating the insulin release mediated through that glucose dependent mechanisms. So this DPP4 inhibitors also form one important group of diabetes mellitus. So what are DPP4 inhibitors? They are sitagliptin, vildagliptin, saxagliptin, and allogliptin. But most importantly, there are even other group of drugs say like tenligliptin. Now, what are the drugs which are very commonly used are one is sitagliptin, another one is vildagliptin, and another one is tenligliptin, which are very commonly used in the routine practice. And they are all orally active and they are selective inhibitors of DPP4 enzyme that deactivates GLP-1. So DPP4 is the enzyme which is inactivating GLP-1 and DPP4 inhibitors will go and inactivate the DPP4 enzyme preserving the GLP-1. So preserving GLP-1 means increased insulin secretion, decreased glucagon release, delayed gastric emptying, suppression of appetite, all of these mechanisms of action which are important in the treatment of diabetes mellitus. And there are certain adverse effects attributed to this DPP4 inhibitors. They are nasopharyngitis and also some distress and diarrhea which can be seen. So now if you
ఎందుకు నోటు బాగోదు
Mallikarjun Rao?
సార్ ఇప్పుడు వినిపిస్తుంది సార్.
Okay, Nanda, thank you. So I was discussing about the drugs which are insulin secretagogues in the past 1 minute. So you have sulfonyl urease, megalithinic analogs, and Dpp4 inhibitors. So all of these agents have commonly one thing in common, that is they all enhance the secretion of the insulin. So this is one important parameter concerned with all these drugs. And then we move on to the next slide, wherein there is say like decrease in the insulin resistance, means the drugs which decrease the insulin resistance. We have only 2 pharmacotherapeutic options available with us, which is 1, we have to increase the insulin secretion, 2, we have to decrease the insulin resistance. And the drugs which are useful are important in decreasing the insulin resistance are biguanides, metformin, thiazolidines, and you have PPAR gamma activator. So you have metformin from biguanides, you have metformin and fenformin as such, but metformin is one of the gold standard drug in the treatment of type 2 diabetes mellitus. It won't be exaggeration to say that there would be no single patient who will not be put on metformin as a basic drug. Everybody will have metformin. Every patient will be given basic first line therapy as metformin, and then only other group of agents like sulfonyl urease, megalithinites, or Dpp4 inhibitors will be added depending upon their response to the hyperglycemic status. So one more group which will decrease insulin resistance are thiazolidines. They are like PPAR gamma activators. That is pioglitazone is one important example from that particular category. Then the sites of action of anti-hyperglycemic drugs, in which the big one, that is metformin, is metformin mainly does its action by increasing the peripheral utilization of glucose by AMPK activation. It suppresses the hepatic gluconeogenesis, and it enhances insulin-mediated glucose uptake and disposal in the skeletal muscle and fat. So these are all the 3 important sites wherein the biguanides, the metformin will act by suppressing the hepatic gluconeogenesis in the liver and enhancing the insulin-mediated glucose uptake and its disposal in both skeletal muscle and adipose tissue. So increased uptake and utilization of glucose by muscles will reduce the insulin resistance. The inhibition of hepatic and renal gluconeogenesis will reduce the hepatic glucose output. And also they will slow the glucose absorption from the GIT. Promotion of insulin binding to its receptor will also be enhanced. So these are some of the important mechanisms by which the biguanides will act. Then coming to pharmacokinetics, there is no plasma protein binding, and as compared to that of the sulfonyl urease, where they have certain plasma protein binding, and then plasma TB half is 2 to 3 hours, and they are excreted unchanged by the kidneys. And compared by then metformin, which is a biguanide, is the primary drug of choice for diabetes by ADA guidelines. ADA means American Diabetes Association. So they have framed certain rules with regard to the management of diabetes by taking into consideration various issues like the glucose levels, their controls, and how well we have to frame the schedules and different plans for treating the diabetes mellitus patients if they are not in control. Means if somebody has say like blood glucose of 120 or 130, or say 140 or 150 fasting, how we have to approach. If there is 200 fasting, how we have to approach. If there is 250, how we have to approach. If postprandial, if it is more than 300, how we have to approach. And how the most important factor that is taken into consideration is HbA1c, that is glycated hemoglobin. So the glycated hemoglobin value or level is taken as an important parameter in monitoring the treatment, along with a very periodic monitoring of the fasting plasma glucose and postprandial blood glucose levels in the body. So normal HbA1c values are 5.6 percent, below 5.6%. If it is 5.6 to 6.5%, it is pre-diabetes. If there is more than 6.5%, it is diabetes mellitus manifest. So anything like 7, 8 and all, despite with treatment, is like fairly controlled. But if it is beyond of 9, it means that the diabetes is not being adequately controlled by that particular drug. And then like we have to change the combination therapies in the patients get, to get the desired response with regarding to hyperglycemia status. And then Mallikarjun Rao,
సార్
Mallikarjun Rao, వినపడుతుందా?
సార్
ఫాలో అవుతున్నారా?
వినిపిస్తుంది వినిపిస్తుంది.
Good. నీకు ఎక్కడ ఎనీ పాయింట్ యూ ఫీల్ లైక్ యు ఆర్ డిస్కనెక్టెడ్, ప్లీజ్ డూ లెట్ మీ నో. ఓకే,
ఓకే సార్.
fine. And then so this is very important thing. Kabatti, in all the patients who are they come to your clinic and they tell symptoms of diabetes mellitus, say like weakness, latitude, polyphagia, polydipsia, or glycosuria. And even if you check their levels by investigations like fasting, postprandial, and HbA1c, so immediately we have to start them on metformin, add one or other sulfonyl urea if the values are very high. Usually the patients come to you when they have very mild disease, but you do have patients who come from village side or semi-rural areas wherein they don't have adequate knowledge to really recognize their symptoms, and they will come too late in the disease process. So it is the time when you have to go for combination therapies in that particular set of patients. Maybe you will not suffice or end up just giving only one drug. So depending upon the values, you have to upgrade or downgrade, up titrate or down titrate the drug dosages as well as combinations. Just to start with, you can go with simple metformin 500 mg. You can go to 1000 mg. Then add one sulfonyl urea or other drugs, like say like Dpp4 inhibitors. So you can try to add and optimize the drug therapy in the patient to give him the optimum benefit of the therapy depending upon his glycemic status in the body. And then there are certain advantages, like how sulfonyl ureas have weight gain. Here they have weight loss, and they can be combined with insulin to reduce insulin requirements. And the most important promising feature of biguanides or metformin is that they decrease the risk of macro and microvascular disease. So in general, diabetes mellitus is an macro and microvascular disease. So it will go and affect the microvessels which are present in the retina, kidney, brain, and other important organs as such. And also they have certain macrovascular effects as well. Like diabetes is one of the most important accompanied disease with myocardial infarction or ischemia, or any blood vessel diseases, say like cerebrovascular accident or stroke, and also any myocardial assaults. So one of the important disadvantages or side effects that can be seen with metformin are nausea, vomiting, diarrhea. Few of the patients complain diarrhea, and they have vitamin B12 deficiency. And apart from this, even you can have lactic acidosis as one of the parameters. Lactic acidosis, but it is more so with one of the prototype, that is fenformin, not with metformin. Metformin is widely acclaimed, very safe, very efficacious drug, which is used as a basic fundamental drug, after which we will be adding other drugs as well. Biguanides. So yeah, as I have told, like, the metal case is one thing, anorexia, flatulence, diarrhea, and these are have been there. As I told you, like fenformin, it has been discontinued because of the lactic acidosis. Sir. Sir. Okay. And then we have thiazolidines, drugs. So this is a new class of drugs which act as agonists to nuclear receptor PPAR gamma in adipose tissue, skeletal muscle, and the liver. Thiazolidines means apart from the biguanides, thiazolidines are the group of drugs which, acting at various tissue levels, will bring the insulin resistance down by totally different mechanism. So what is the mechanism of action is stimulate the nuclear receptor, peroxisome proliferator activated receptor gamma. So these receptors promote the transcription of responsive genes which control glucose and lipid metabolism. Means they will increase the insulin sensitivity and decrease the insulin resistance. They promote the uptake and utilization of glucose by increasing the GLUT4 transporters, and they decrease the glucose output by inhibiting gluconeogenesis. So these are some of the important mechanisms by which PPR gamma will be acting at different tissues, say like cutting across adipose tissue, muscle, and liver. So in liver, they will decrease the gluconeogenesis. In muscle and fat, they will increase the transcription of insulin responsive genes, which will control the glucose and lipid metabolism, thereby enhancing the insulin sensitivity, thereby decreasing the insulin resistance at large. So this is the role of thiazolidinediones. And then you have pioglitazone and rosiglitazone, in which pioglitazone is one drug which is being commonly used as such, and the duration of action of it is more than 24 hours. It is given in the doses of 10 to 45 mg. And one more drug was there in that group, that is rosiglitazone, but due to some issues with regard to its side effects, because it was found to be associated with increased risk of heart failure and MI, it is discontinued. It is no more available in public domain. So pioglitazone is very important. Then you have other miscellaneous agents. They are alpha glucosidase inhibitors, as I've shown you, acarbose, miglitol, voglibose. Then amylin analog, that is pramlintide. Then dopamine 2 receptor agonist, that is bromocriptine. Then SGLT2 inhibitor, that is dapagliflozin. So alpha glucosidase inhibitors. So how they are important and all. Alpha glucosidase enzyme facilitates the digestion of complex starches, oligosaccharides, and disaccharides into monosaccharides. So these are absorbed from small intestine, and the digestion is also facilitated by pancreatic alpha amylase. So this is the function of this alpha glucosidase enzyme, which will split the complex carbohydrate into simpler carbohydrates. And by giving alpha glucosidase inhibitors, the complex carbohydrates will be in the same state and will not be broken down into simple carbohydrates, leading to a rush in the glycemic status in the body. So the examples are acarbose, miglitol, and voglibose. Voglibose is one of the common drugs which is available as 0.2 and 0.3 mg and so on. It is commonly used, and acarbose is also one drug which is commonly used. So they work on the brush border of the intestine, cause carbohydrate malabsorption, reduce post-meal hyperglycemia. So immediately as soon as you eat the complex carbohydrate, that will not be cleaved down into smaller carbohydrates or sugars, in fact glucose, and they will see that they will put in control on the overall glycemic status of the body. And their regular use along with metformin and other sulfonyl urease may add value to the patients who are having higher postprandial levels to have good control over it. Then mechanism of action, same thing what we have been telling. Then PK, yeah, PK is one thing, like absorption of acarbose is minimal, but miglitol is absorbed well, and a part of acarbose is excreted and the advantages of this particular drug is they are selective for postprandial hyperglycemia, postprandial hyperglycemia. Then you have no hypoglycemia. They have disadvantages. The important disadvantage being abdominal distension or flatus, only effective in mild hyperglycemia. Mallikarjun,
Sir.
screen
Sir.
కనిపిస్తుందా?
కనిపిస్తుంది సార్.
స్క్రీన్ కనిపిస్తుందా?
కనిపిస్తుంది సార్.
So these are all important group of drugs. So if you are giving, so if diabetic pharmacology, watch your if they tell you are having some nausea, metallic taste, abdominal discomfort, you have to suspect two drugs. One is metformin. Suppose they come and tell you are feeling very weak, hypoglycemic, they come tell such complaints, you should suspect of some dosage problems or changes that have to be done with sulfonyl urea group of drugs. So this is important thing. So every drug, it has a efficacy and also it has certain limitations to do with. As we should be able to. Yes, some problem. So physicians, you have to balance as well as have to balance efficacy as well as the patients. Then yeah, we have one more group like co-transporter 2. So here the site of action is kidney. Here the site of action is kidney. So in which you have SGLT2 inhibitors. They are newer anti-diabetic drugs, and what is their importance is kidney continuously filters. The cardio is disconnected again. Kidney continuously filters glucose through glomerulus, which is reabsorbed back from proximal tubule by sodium glucose co-transporter. So you have sodium glucose like co-transporters. They are called as SGLT2 receptor channels, which are present in the proximal tubule of the kidney, wherein sodium along with glucose, both of them are reabsorbed back into the from the kidney back into the blood. So here, if you are using SGLT2 inhibitors, so they will decrease the glucose reabsorption, of course, along with sodium as well. Means the glucose will not be again taken back from the proximal tubule into the kidney. So thereby the glucose will be going out of the body, whichever is excess. You take food, your blood is completely with full of glucose, and it is not properly taken up by the peripheral tissues, say like liver, muscle, and adipose tissue for proper glucose utilization and its absorption. All of will it be dumped into the kidney. So when there is excess of glucose available to be filtered by the kidney, and it is being absorbed back from the proximal tubule from these channels, that is sodium glucose like transporters. So here you can use drugs like dapagliflozin and remogliflozin, who will go and inhibit that particular receptor and see that the glucose is not absorbed back into the circulation, and the glucose will go through down in the urine. So this is one thing. And the advantages of it is it can produce weight loss, and there will be no hypoglycemia with regard to its mechanism of action. But the disadvantages being polyuria, and there will be more polydipsia as a consequence of it. And due to the transport of glucose more from the urinary tract, it can predispose the patient to more frequent UTIs or urinary tract infections, apart from the hyponatremia, which is an associated loss, because as this particular drug is used, it will see that both sodium and glucose are not reabsorbed back into the body. So this is one important thing, like one need to remember. So in a nutshell, if we have to put the entire class, so we are having different agents which are used as oral hypoglycemic agents with varied mechanisms of action, broadly divided into the agents which enhance the insulin secretion, which are sulfonyl urease, in which you have first generation and second generation. First generation chloropropamide and tolbutamide, which are not used nowadays. Second generation, which are very important group of drugs, which are used as almost as first line agents in all the patients. They are glimepiride, gliclazide, gilblenclamide, and so on. So these drugs can be selectively used depending upon the need and the patient and their glycemic status selectively. But the risk of these drugs is they produce hypoglycemia, and they can transfer through the placenta and go to the fetus and cause hypoglycemia. So their use is to be strictly restricted in patients who are having gestational diabetes mellitus. Other important and safe group of drugs, that is Megalithinites, which are sharing the same mechanism of action as that of sulfonyl urease, are comparatively better, which can be used on long-term basis in both patients with liver and kidney abnormalities, as well as they have lesser risk of hypoglycemia as compared to that of sulfonyl urease. And third category of drugs which come from this particular group of drugs is the Dpp4 inhibitors, so which will go and inhibit the breakage or cleavage of the peptide GLP-1 and GIP by acting on the enzyme dipeptidyl peptidase 4, and they can also aid in restoring that insulin secretion adequately in patients who are having type 2 diabetes mellitus. Coming to second important group of agents wherein they will enhance the insulin sensitivity or decrease the peripheral insulin resistance. They are big warheads, in which metformin is the gold standard drug. So there will be no prescription from a doctor treating diabetes patient without metformin. So this comes from big guanides. We have fenformin as well, but that is discarded or not used anymore due to the side effect of lactic acidosis. But fenformin in the doses of 500, 750,000 mg available as direct preparations and are also extended or SR, sustained release preparations. They can be safely used in patients depending upon their glycemic status as monotherapy or also as combination therapy by combining it with sulfonyl urease, megalithinites, Dpp4 inhibitors, and other agents. So this is another group of important drugs. And one more important group is the glitazones. So glitazones also can be used by their nuclear receptor mechanism of action by acting on the PPR gamma receptors, which will go and produce the insulin responsive genes and mediate the metabolisms for efficient glucose uptake and decreasing the insulin resistance and increasing the insulin sensitivity in tissues like muscle, adipose tissue, and liver, and produce the desired glycemic status in the body. Apart from it, there are other miscellaneous agents, say like alpha glucosidase inhibitors, which are used usually to control the postprandial hyperglycemias in combination with the first 2 or 3 group of drugs to produce the desired benefit. And then you have SGLT2 inhibitors, which are also used in combination therapy in certain set of patients, wherein you can directly try to inhibit the sodium glucose like co-transporter present on the proximal tubule and ensure that the glucose is not reabsorbed back into the body, which can also aid in producing the hypoglycemic effects. So these are certain and some important group of drugs which everybody needs to remember as far as these things are considered. And I request all of you people to go back, open your textbooks, standard textbooks, and read in detail about it with regard to the control of pharmacotherapy of treatment of diabetes mellitus. I think this will call for the class. Just try to ensure like how many people are there, how many have listened. Nivedita, are you there? Akila, Hanisha, Neeraj, Bhavana, Dharani, Rashekar, Bharat. Nobody is there in the class. Mallikarjun Rao.
Sir,
GRI పాపానికి నువ్వు ఒక్కడే మాట్లాడుతున్నావు కదా కృష్ణారెడ్డి
Present, sir.
కృష్ణారెడ్డి
Sir.
ప్రెసెంట్ ఒకసారి ఒక పని చేస్తానంటే అసలు ఇలా Now I will take the attendance. Hope all of you are there. Roll number 1.
Present, sir.
2.
Present, sir.
3.
Present, sir.
4.
present, sir.
5.
5 present, sir.
6.
6 present, sir.
7.
7 present, sir.
8.
8 present, sir.
9.
9 present, sir.
10.
10 present, sir.
11,
11 present, sir.
12,
12 present, sir.
13,
13 present, sir.
14,
14 present, sir.
15,
15 present, sir.
16,
16 present, sir.
17,
17 present, sir.
18,
18 present, sir.
19,
19 present, sir.
20,
20 present, sir.
21,
21 present, sir.
22,
22 present, sir. 22 present.
23,
23 present, sir.
23, 24,
24 present, sir.
25,
25 present, sir.
26,
26 present, sir.
27,
27 present, sir.
28, 28, 29,
29 present, sir.
30,
30 present, sir.
31,
31 present, sir.
32,
32 present, sir.
33,
33 present, sir.
34,
34 present, sir.
35,
35 present, sir.
36,
36 present, sir.
37,
37 present, sir.
38, 38, 39, 40,
40 present, sir.
41,
41 present, sir.
42,
42 present, sir.
43,
43 present, sir.
44,
44 present, sir.
45,
45 present, sir.
46,
46 present, sir.
47,
47 present, sir.
48, 48, 49,
49 present, sir. 49
50
present, sir.
present, sir.
51,
51 present, sir.
52,
52 present, sir.
53,
53 present, sir.
54, 55,
55 present, sir.
56,
56 present, sir.
57,
57 present, sir.
58,
58 present, sir.
59,
59 present, sir.
60, 61,
61 present, sir.
62,
62 present, sir.
63,
3 present, sir.
63, 64,
64 present, sir.
65,
65 present, sir.
66,
66 present, sir.
67, 67, 67,
67 present, sir.
68, 67 present,
68 present.
68, 69,
68 present. 69 present, sir.
70,
70 present, sir.
71,
71 present,
71, 72, 73,
72 present, sir.
73
73,
present, sir.
74,
74 present, sir.
75,
75 present, sir.
76, 76,
56 present, sir.
77,
77
78,
present, sir.
78,
present, sir.
79, 79, 80,
80
79,
present, sir.
81,
81 present, sir.
82,
82 present, sir.
83,
83 present, sir.
84,
84 present, sir.
85,
85 present, sir. 86 present,
87,
sir.
87,
87 present, sir.
88, 88,
88 present, sir.
89,
89 present, sir.
89, 90,
90 present, sir.
91,
91 present, sir.
92,
92 present, sir.
93,
93 present, sir.
94,
94 present, sir.
95, 95,
95 present, sir.
96,
96 present, sir.
97,
97 present, sir.
98,
98 present, sir.
99,
99 present, sir.
100,
100 present, sir.
101,
101 present, sir.
102, 102 present, sir. 103,
103 present, sir.
104,
Present, sir.
105,
105 present, sir.
106,
106 present, sir.
107,
107 present, sir.
108,
108 present.
109,
109 present, sir.
110,
Present, sir.
111,
111 present, sir.
112,
112 present, sir.
13, 114, 114,
115 present, sir.
115,
115 present, sir.
114, 116, 116,
Overreaction.
115, 115. See, whatever you are talking, I am able to hear. You go aside and talk now. You are talking with your family members, everything is coming into my ear. 115, 115, okay, I think it's a 116, like option.
115
117,
present.
117 present, sir.
115 present, 116,
118 present, sir.
116 absent. Sorry, 118, okay, 119,
118
119
present.
present, sir.
119, 120, 120, 120, 121,
121 present, sir.
122, 123,
122 present, sir.
okay,
123 present,
123,
sir. 123
124,
present, sir. 124
124,
present, sir.
125,
125 present, sir.
126, okay, okay, 126,
126 present, sir.
127, okay, 127,
127 present, sir.
128, 129,
129 present, sir.
128, 128 absent, 128, 130,
130 present, sir.
131,
131 present, sir.
132,
132 present, sir.
133,
133 present, sir.
134,
134 present, sir.
135,
135 present, sir.
136,
136 present, sir.
136, 137,
137 present, sir.
138,
138 present, sir.
139, 139, 140,
140 present, sir.
141,
141 present, sir.
142,
142 present, sir.
143,
143 present, sir.
144. People who have finished giving attendance, I think they can go, because it's creating disturbance talking with family members and all that. 144. 144 absent. 145.
146 present, sir.
146. 47.
147 present, sir.
48. 148. Classes and numbers 148. 148. Ram, are you there? 148.
Present, sir.
148 present or absent?
Present, sir.
Okay. This is the first number, huh? Ram?
Sir, present, sir.
So,
Ram.
Sir.
sir, 128 present, sir.
Sir, 146 present.
Sir, roll number 2 present, sir.
2 present, sir. Next. Okay.
Sir, 145 present, sir.
128, sir.
128 చెప్పావమ్మా, ఇంకెన్నిసార్లు చెప్తావు? అయిపోయింది. You are given
140 145 present, sir.
140.
145, sir. 5, sir.
మీ క్లాస్ ఎంతమంది చెప్పు? మొత్తం 148 కదా మీ క్లాస్?
Yes, sir.
లాస్ట్ ఫణి శ్రీరామ్ నేనా?
Yes, sir. 148 present, sir.
అదే నువ్వే లాస్ట్ కదా, అయిపోయింది ఇంకా అంతే.
Sir, 145 present, sir.
హలో, వేసానన్నా వేసా. ఈ ముక్క చెప్పండి రా బాబు. మొత్తం ఉండదు 148 కదా మీ క్లాస్ లో?
Yes, sir. 148.
ఓకే, డన్. గుడ్, వెరీ గుడ్. వేసానులేండి. 145 ప్రెసెంట్ వేసా. భరత్,
Thank you, sir.
ఓకేనన్నా. చదువుకోండి మిగతా వాళ్ళందరూ.